You know, whenever we talk about the NHS, it always seems to come down to the same two things, right? Funding and staff shortages. But what if that's not the whole story? What if the biggest, most fundamental problems are hiding somewhere else entirely? In this explainer, we're going to dig deeper than the headlines. We're going to look at the actual architecture of the NHS and ask a pretty provocative question. Is this a crisis of resources, or is it a crisis of rules?
Wow. This quote, it just cuts right to the heart of the matter, doesn't it? Imagine being a doctor or a nurse, and you're held accountable for things going wrong. Things that are completely outside of your control, because the system itself is broken. That's not just a professional headache. It's a huge moral burden, and that's exactly why this is the perfect place for us to start.
So yeah, this is the big question we're going to be wrestling with. All those things we hear about and experience, the crazy long wait times, the exhausted staff, the burnout, is it really just about not having enough money or enough people? Or is there something deeper, something structural going on with how the whole thing is designed and run?
All right, so let's get into it.
First up, a system under strain, looking at the visible cracks.
Now, it's really easy to think of these as two separate issues, right? You've got the workforce crisis over here and the patient safety crisis over there. But what we're going to see is that they're not separate at all. They're basically two symptoms of the exact same underlying disease. They both flow from the same source, a broken governance architecture. You just can't fix one without fixing the other.
And this is where it gets really real, the human cost. For the staff, we're talking about more than just being tired. It's this thing called moral distress. It's that gut-wrenching feeling of knowing exactly what your patient needs, but the system itself stops you from providing it. And for patients, it's that awful, terrifying experience of being passed from one team to another and feeling like you could just fall through the cracks at any moment.
So, that idea of falling through the cracks brings us to our next big topic, the fragmentation problem. Let's talk about where the pathway breaks.
So what is pathway fragmentation? Well, it's basically what happens at the borders between different parts of the healthcare system. Think about when you move from the hospital to care in the community. At that handover point, responsibility gets fuzzy. It's like the patient's care becomes a hot potato, and nobody wants to be the one left holding it. No single person or team clearly owns the whole journey.
This visualizes it perfectly. It's like a relay race, right? The hospital team runs their leg, they get to the handover point, but there's nobody there to take the baton. That's the unowned transition. It's a massive gap where the baton, the patient's care, is literally dropped. And that is a huge, huge risk to patient safety.
And this leads to something with a really powerful name, a discharge into a GP vacuum. Just think about that. The hospital discharges a patient, but the information doesn't properly follow them. So the GP is left completely in the dark, expected to manage complex care without the full picture. The patient isn't really in the hospital's care anymore, but they're not fully in the GP's care yet either. They're just stuck in a vacuum.
Okay, so this fragmentation, it isn't just a series of unlucky accidents. It's a symptom of a much deeper issue. Which brings us to Section 3, the accountability gap, or how we get from the blueprint to a total breakdown. And this is probably the most surprising part of the whole story. The issue isn't that we don't have rules. The legislation is often already there. On paper, there are legal duties for different parts of the system to cooperate. The problem is the massive gap between what the law says and what actually happens day to day. It's like having a rule book that everyone knows exists, but nobody is actually following or enforcing. I love this blueprint versus building analogy because it just makes so much sense. The blueprint, that's the law, says we need a duty to cooperate. It's supposed to be a solid, joined-up structure. But the actual building we've ended up with? It's full of those unowned transitions and diffuse responsibilities. It's like the builders ignored the plans, and now the whole thing is unstable. There's a huge difference between what was designed and what was actually built.
And this isn't some old historical problem either. The accountability map is literally changing under our feet. Just look at what happened in February 2023. NHS Digital, which used to be this standalone body responsible for national data, was basically abolished, and its functions were absorbed into the mothership, NHS England. Now, that might sound like a boring bit of administrative shuffling, but it's a huge deal. It completely changed the accountability chain, arguably making it even less clear who's responsible for what.
So, the million-dollar question, who is actually accountable?
I mean, on paper, it looks clear enough. You've got Parliament at the top setting the laws, then NHS England leading the system, then local boards commissioning services, and finally the trusts and local authorities on the front line delivering care. But look at those question marks between the layers. That's the problem. Those arrows are supposed to represent clear lines of accountability, but in reality, they're weak or even broken. Orders from the top get lost in translation, and feedback from the bottom never makes it up. The whole system can't learn from its failures.
Okay, so we've laid out a pretty big problem. But what's the way forward? Well, the solution we're going to look at is maybe not what you'd expect. It's about building a bridge, not launching another huge reform.
Right. So the argument here is that the last thing the NHS needs right now is another massive, top-down, disruptive reorganization. We've been there, done that. The idea isn't to knock everything down and start again. It's to make the system we have actually work the way it's supposed to. And the key to that is two words: enforceable coordination.
So how do you get that enforceable coordination? Well, one of the main tools proposed is something called a Memorandum of Understanding, or an MOU. Don't let the formal name fool you. Think of it as a practical, formal agreement. It's basically where two organizations, like a hospital and the local council, sit down and write out, black and white, who is responsible for what, especially at those really dangerous handover points.
And an MOU does exactly what's needed to fix the problems we've been talking about. First, it clarifies who owns the patient's entire journey, end to end. No more dropped batons. Second, it defines the bare minimum for things like sharing data, so the GP isn't in a vacuum. And maybe most important, it creates a clear plan for when things go wrong, who you call, what the next step is. It's all about turning that broken blueprint into a solid, working building.
And that really brings us right back to where we started. This quote sums it all up. The workforce crisis, the patient safety failures, they feel like resource problems, but they are absolutely, fundamentally a problem of governance and accountability. And if that's the diagnosis, then the cure isn't just throwing more money at it. The cure has to be about fixing the underlying structure and enforcing the rules.
Which leaves us with one final and honestly pretty challenging question to think about. If, as we've seen, the rules often do already exist, if they're sitting there in legislation, then the real issue isn't about writing more rules. The real issue is enforcement. So, who's responsible for making sure the NHS actually follows the rules we already have?